the human body is complex, right? Gait is a complex movement and something that we're all doing every single day. I would also argue that looking at some of the impairments outside of, that exact area of pain could also explain ongoing or persistent symptoms. Maybe that is that missing link to why someone keeps coming back to you with the same symptoms once a year.
Kelli, welcome to the podcast.
Thanks so much for having me.
You're in the Mile High State. You're a physical therapist at UC Health. Do I have that right?
Yeah, that's correct.
Look at that. I can Google. Congratulations. We can Google. You're presenting at the AAOMT Conference, which is far from Colorado. It's at sea level. Are you going to be okay? Are you going to adjust to that coming from Colorado?
I'm going to feel great.
You're going to feel good.
Yeah.
That's what you want to do.
Minus the humidity.
Right. Right. But it's October. That's October, November, December. That's when you want to be in Florida. That's the way to do it, Kelli. You're smart. You train, live in Colorado, come to sea level, and you can blow us away. So you're presenting at the AAOMT Conference, and we want to give a little teaser. So let's just start from the start. What do you get to share? What do you get to teach people this year at AAOMT? And we'll learn a little bit. But this is the tease before the tease.
Yeah, good question. So I will be presenting with two of my colleagues on an out-of-the-box approach to regional interdependence specific to the lower extremity. So the title of our presentation, it's going to be two parts. The first part is going to be talking about a top-down approach, and the second part will be talking about a bottom-up approach. And in both, we'll be giving case scenarios, showing videos of Gait from different patient presentations, and then, giving attendees some different ideas of techniques they can use to treat those deviations.
You've got to mention your co-presenters, or they would feel left out. They're not here right now, but who are they?
Yeah, they would. So it's Dr. Baum and also Dr. Beth Geiser.
Now you're good. You've got them in there. You've snuck them in. We got them in the beginning. All right. So let's give a little tease. The presentation with your co-presenters is going to be a little more robust, and that's how we get you, right? We're going to teach you right now while you listen on the podcast or watch them on the video. But you're going to learn more when you come in person. And I've been to the AAOMT Conference, pretty robust. So go to the website, link in the show notes in the bio to find out more. But let's start with this. Help us understand the importance of gait analysis in physical therapy. How does it impact patient outcome? Like, what's the outcome? Patient outcomes, particularly in your area, orthopedics and lower extremity amputee care.
Yeah, so gait analysis is an extremely important tool in our toolbox as physical therapists. And this is certainly true in orthopedics, but other areas of PT practice as well. We use it as an assessment in terms of how does someone use their range of motion, their strength, their flexibility, right? All those good things, and execute a very necessary functional task. And I think sometimes we forget about movement observation as an assessment tool that actually provides more meaningful information for me than a single special test when it comes to assessment. As for the patient outcomes part of your question, I can't tell you how many times a week patients tell me their goal for therapy is to walk again. Whether it's they want to walk pain-free, they want to walk further, they want to walk faster, right? Or walk, period. And, what better way to help them meet that goal than to provide specialized intervention based on the way they walk? And, I think that's especially true when you're working with individuals following limb loss. But the added layer is figuring out whether their gait deviations are driven by musculoskeletal impairments, prosthetic alignment issues, or a combination of the two.
All right. So we mentioned top down, bottom up, right? Burning the candle at both ends. Go a little deeper, elaborate. Top down, bottom up approaches you mentioned. How do those strategies differ besides the top and bottom, obviously? And in what situations would each be most effective?
Yeah, so both strategies are based in concepts of regional interdependence, right? And so I think in school we've all learned, or in the clinic, we've all learned some element of, your knee pain may be related to impairments at the hip, or, foot and ankle pain might be related to impairments up at the hip. Our presentation is just going to be providing a more systematic way of looking at that and treating that. So for a top-down approach, that term is going to be referring to starting at the hip and then systematically going down to the knee, and then to the foot and ankle. And bottom up will just be vice versa. Start at the foot and ankle, then work your way more proximally up the kinetic chain. For simplicity purposes, right, this is a teaser, you might choose a top-down approach when you're treating an individual who has low back pain, hip pain, pelvic pain, right? Because looking at the hip more proximally, that might be the most plausible, explanation for their symptoms or their gait deviations. But maybe the patient isn't improving the way you thought they would, or their gait deviation isn't changing. And then you could start to consider, following our approach, looking at the knee and then the foot and the ankle. As for bottom up, same idea, it might be most relevant for a patient experiencing foot and ankle pain, right? That kind of makes sense to us. But kind of as I was mentioning, if they don't respond to the way you're expecting them to, you have to start considering contributors more proximally, because the foot and ankle is really just the first contact point on the ground in the gait cycle. And then a lot happens from there.
All right, well, we've got to bring in some sort of manual therapy technique, right? Because you're presenting at AOMT, and that's sort of a common thread. So help us understand, maybe give us an example of a few techniques that you might use and explain how they address gait-related problems specifically.
Sure. So let's start at the hip. So let's say you see a patient who is having a really short stride length, meaning they're not getting into full hip extension at that terminal stance phase of gait. Maybe you try going to a prone P to A or posterior to anterior mobilization to the hip to improve extension. Right? And I think we would maybe all logically start there. Also looking at, I know you asked about manual therapy techniques, but also looking at hip flexor length and kind of other contributors to that limited mobility. But a more out-of-the-box approach to that specific gait deviation would be to maybe use the side-lying lumbopelvic mobilization or even manipulation to promote more anterior rotation of that innominate, which is a very necessary part of hip extension, right? So kind of thinking out of just that femoroacetabular joint. At the knee, a common deviation I see is patients remain in slight knee flexion throughout the entire gait cycle, right, which would be abnormal into stance phase. Very important that patients be able to access that terminal knee extension. And so I would start by assessing, various accessory motion around the knee joint or the knee complex. But we have to think about, not only a posterior glide of the femur on the tibia or an anterior glide of the tibia on the femur, but think about the screw home mechanism of the knee and that combination of that glide and rotation that happens, as well as that proximal tibiofibular joint, right? Is that joint moving as well? We could also consider doing some interventions for superior patellar glide, right? We have to kind of figure out, why isn't that patient able to access knee extension? Well, do they have it? And then are they able to access it? And, our presentation particularly is going to be really incorporating a lot of themes from that screw home mechanism and more of those combined movement patterns. Next, kind of going down to the foot and ankle, the most common thing I see, and I'm sure other therapists, when they hear this, are going to be like, yeah, me too, is limited ankle dorsiflexion. That's, by and large, the most common deviation at the foot and ankle. And so that might look like an early heel rise in gait, or they may externally rotate their foot so that they're avoiding dorsiflexion and great toe extension and midfoot pronation altogether. We've all learned that talar curl distraction manipulation. I also like to treat the subtalar joint for that with a similar technique, but just changing the pre-positioning of the foot and the ankle to bias one over the other. And then I like to follow that with a talonavicular joint treatment. So whether that's a mobilization or a manipulation, I typically treat that in prone because we know that dorsiflexion and pronation are coupled movements, right? Especially, applicable to that stance phase of gait. And keep in mind that in mid-stance, we also need controlled internal rotation at the hip. So going right back up the chain.
Yeah, bottom up, top down. Your presentation at the AAOMT conference this year is going to emphasize the collaboration and synergistic movements within that lower extremity in the kinetic chain. How can physical therapists ensure that they're not missing critical links? PTs are always scared. What are we missing? So
Yeah.
and have them do it again. So how can you make sure PTs ensure they're not missing critical links in the chain when assessing and treating their patients?
Yeah, great question. I think the main message that we want to send with our presentation is consider impairments in other areas of the kinetic chain that might contribute to symptom development. I think in PT school or maybe in residencies or if you pursue fellowship, you really get hammered home with more of that, look elsewhere approach. But it's easy to get into the clinic and start seeing patients and get into a rhythm, and you kind of start to forget about things that are outside of that patient's pain zone, right? Or their exact location of symptoms. But the human body is complex, right? Gait is a complex movement and something that we're all doing every single day. I would also argue that looking at some of the impairments outside of, that exact area of pain could also explain ongoing or persistent symptoms. Maybe that is that missing link to why someone keeps coming back to you with the same symptoms once a year, right? Or maybe it's every 2 years or something like that. And, we do have evidence support that when someone has experienced low back pain, they're at an increased risk for recurrent back pain again in the future. And so I would offer that if we begin to consider those other areas and think about, how someone moves more generally, I think we might be able to decrease that risk and fully return people to function. I think it's also helpful. I think I may have mentioned this already, but when you get stuck with a patient and you're just like, I do not know what else to do for this person. I assessed their foot and ankle. I treated what I found, and I don't understand why it's not getting better, right? We've all been there, right? Where we get frustrated and you run out of treatment ideas. And so I would say turn towards function and start to assess their gait. And one way you can really make sure you're not missing more subtle deviations or asymmetries is to use video analysis. There's a lot of really great apps out there that are totally free, or just the iPhone camera has that slow-mo feature. And sometimes that gives me enough of a brief look, and I'll even record it on the patient's phone, right? So they can see it. And then you get that buy-in and you can record it again on their phone a few months from now, and they can compare their progress. So I've had good success with that. And also, if you do record on your own phone, just remember with HIPAA to delete it and not keep it on your phone. But video analysis can be super helpful.
Yeah. All right. Well, physical therapists love examples. We love the case study. Love to tell. I was working with this person. So we like to share. So, give us a real world case study or example where the application of the techniques you just talked about are going to help improve a patient's gait. What were the key takeaways from that particular experience?
Yeah, so the case that kind of stands out the most to me where this has happened recently is I had a patient with a really complicated orthopedic history, relatively young guy. He fractured both of his tali with a relatively low impact incident. He brought his dirt bike to a stop, put his feet on the ground, and broke both of his tali, which is kind of crazy. So he had surgery. They did an open reduction internal fixation for both of them. Long journey in recovery. I did not treat him after that original surgery, but that surgery was successful for his left ankle. His right ankle, on the other hand, continued to have pain and just ongoing mobility limitations and felt super stiff. So he went back to the surgeon, and they decided to take the hardware out and see if that could help with his pain and his symptoms. And so that's when he was then referred to me, was after the hardware was taken out. So when I looked at his gait during the evaluation, I noted a few different things. So I saw that he had a really early heel rise, so kind of showing some of those signs of that lack of ankle dorsiflexion. He had decreased midfoot pronation in that stance phase, a lack of terminal knee extension, right? All of those movements go together, so that does make sense. And then he also had that decreased stride length that I was talking about, a lack of hip extension. So in my examination, obviously I'm going to look at range of motion, strength, right? All those bread and butter things that we all know and love in PT. And in doing so, I cleared his hip. So I think most people, when they would get that referral for someone after hardware removal in the ankle, they may not go look at the hip on day one,
Right.
but I did, right, just to clear it. And so I didn't find any substantial impairments at the hip. And so that kind of led me towards, I think this is really more foot and ankle driven, which is more kind of traditional based on the referring diagnosis, right? So when I looked at his knee, I actually found he had a lot of hypomobility or decreased movement at that proximal tibiofibular joint, which again makes sense when you're talking about the ankle complex, but might not be something you would look at with every post-op foot and ankle patient.
Sure.
So I treated that joint with manipulation a few times, a couple sessions, and that actually cleared that up pretty quickly, and that restored his knee extension. So that was pretty cool. And then I focused most of my time and energy on those impairments in the foot and ankle. So I did a lot of treatment to his talar curl joint, the distal tibiofibular joint, subtalar joint, and then his talonavicular joint was just super locked up. Makes a lot of sense with the injury that he had. But I actually think treating his talonavicular joint restored more of a normal gait pattern than even treating talar curl, which may surprise some people, certainly surprised me in this case. He benefited from treatment of both areas, but ultimately that approach was successful in minimizing his gait deviations. So the time to his heel rise was delayed. It's still not perfect if I'm being picky, but he got back full pronation in stance phase, and his stride length is symmetrical. So to me, that's a huge win. In terms of, kind of where's his plan of care now, his dorsiflexion is still a bit limited, but in communication with his surgeon, she's kind of said she doesn't think further improvement is really possible. He's certainly developing some of that early post-traumatic arthritis. So we're really in a maintenance phase of care now, transitioning towards independent management with a gym program. He does a lot of self-mobilizations at home, which has helped us get a lot more carryover, and a lot of corrective exercises, right? This is certainly a manual therapy conference, but shameless plug for corrective exercise, right? You have to do that to get those corrections to stick. And for him, that's been a huge component as well. So we're really just trying to optimize things as much as we can and prolong time to another potential surgery.
That's great. I like how you told that in the story. A lot of takeaways from that. Most importantly for me is I now know what the plural of talus is.
Yeah, I don't know. I'm hoping I got that right.
Talus
I would assume I didn't take Latin in high school, so.
I think you said it on the podcast, and since it's recorded, no one can change it.
Yeah, there we go.
And if they're going to confront you, it's going to be when you walk off stage at the AOMT conference this year.
And we'll have a really fruitful discussion about the plural form of talus.
That's the thing to have over a drink in the networking hour. It's my suggestion for that location. Kelli, last thing we do on the show is final thoughts. Is there anything you'd want to sort of leave with the audience? This is your chance for a plug to, be there for your presentation in person. But what would you want to leave with the audience of your colleagues today?
Yeah, sure. I would say just a message to, continue to look above and below the area of the patient's pain involvement. Think about them as in their movement as, more generally as a human being, right? What do they need to execute the task that they're having trouble with? And we could even go on and on and on about into the trunk and mobility limitations there. But I think that's really the take-home message. And then obviously have to say, come to the presentation to learn more techniques. And we're going to be creating a video gallery and a private YouTube channel that people can take with them. Because I don't know about you, but sometimes I go to these great courses or conferences, and in the moment, I'm like, I'm totally going to remember this. And I don't. Right? You get back to clinic and you're like, where were their hands again? And, everyone's trying to take videos on their cell phones, but you get someone else's cell phone in your view and it just doesn't work well. So we're going to actually create a video channel afterwards where people can go back and look at those techniques and hopefully use them more consistently and successfully in the clinic.
That's what I like to hear. Kelli, I hope to see you in Orlando, maybe with Mickey Mouse or Minnie Mouse ears. You're so close in proximity. You've got to kind of touch on Disney for the day. But thanks so much for sharing what you'll be talking about with your colleagues this October with AOMT.
Yeah, thanks so much for having me.